This is Randy Schell, and I'm making a video cast, part 3 of a 3-part series on anesthesia pharmacology. It's part of our keyword review at the University of Kentucky Department of Anesthesiology. As a reminder, part 1 and part 2 covered local anesthetics, neuromuscular blocking agents, opioids, and IV induction agents, and part 3 will continue the topic of inhaled anesthetic keywords, pharmacogenetics, and then some miscellaneous pharmacology topics. The first keyword is vaporizer filling air. What if you could put the wrong liquid volatile anesthetic in an inappropriate vaporizer? What would happen? You would need to know vapor pressure of inhaled anesthetics. The vapor pressure of desflurane is very high at about 670. That's the reason why we need the special vaporizers that desflurane is provided in that keep it at 2 atmospheres and 39 degrees so that we can deliver it accurately. Isoflurane's vapor pressure is 240 millimeters of mercury, and sevoflurane is the least at 160. And we should say these are the vapor pressures at 20 degrees centigrade because vapor pressure is proportional to temperature. As temperature goes up, vapor pressure goes up. As temperature goes down, vapor pressure goes down. But these vapor pressures, 670, 240, and 160, are independent of atmospheric pressure. So whether the isoflurane is at sea level or up at Denver at over 5,000 feet elevation and lower atmospheric pressure, the vapor pressure is the same. We also need to know MAC. Historically, remember, halothane is one of the most potent anesthetics we've had at 0.76%. Isoflurane of our currently used volatile anesthetics is very potent at 1.2%, Sevo at approximately 2%, and desflurane at approximately 6%. So as an example, let's say, what if we put isoflurane in a halothane vaporizer? Isoflurane and halothane have the same vapor pressure, so if you set the dial of the halothane vaporizer at 1.5%, thinking that you're giving 2 MAC of halothane, the vapor pressure being equal, you'd still deliver 1.5%, but it would be 1.5% isoflurane, or just over 1 MAC of isoflurane. So you'd be delivering less than 2 MAC isoflurane. What if I could put isoflurane in a sevoflurane vaporizer and you set the dial at 4%, thinking you're delivering approximately 2 MAC of sevoflurane? But instead, iso is in there. The vapor pressure of isoflurane is greater than sevoflurane, and therefore more than 4% would be delivered, and not only would it be more than 4%, but it would be 4% isoflurane, which has a higher MAC, which is more potent, that is, a MAC of 1.2%, and it would be greater than 3 MAC of iso instead of 2 MAC of sevoflurane. What if I could put desflurane in an isoflurane vaporizer? The high vapor pressure of des results in rapid and very high overdose, and again, that is the reason, that high vapor pressure of desflurane, why we have to have the special desflurane vaporizer to be able to accurately deliver desflurane. Next keyword is anesthetic delivery at altitude. And to understand this, you need to know MAC as a partial pressure and the way that the vaporizers function with changes in atmospheric pressure. So let's use 2 examples. The desflurane vaporizer, or the Tech 6 vaporizer, calibrated at sea level and set at 1 MAC, or approximately 6%, that vaporizer will deliver 6% whether you're at sea level or up at a higher elevation. So 6% desflurane, it's 6% of 1 atmospheric pressure, or 760 millimeters of mercury at sea level. That's 46 millimeters of mercury. And we could say the MAC of desflurane is 46 millimeters of mercury most accurately. But normally we express MAC in a percentage, and we should say at atmospheric pressure and at 20 degrees when we say 6%. Desflurane 6%, if you took it up to 7,000 feet elevation, that vaporizer continues to deliver 6%, but now at 7,000 feet elevation, the pressure around it is only 600, so 6% of 600 is only 36 millimeters of mercury, which is less than 46 millimeters of mercury, obviously, and you'd be underdosing the patient. Therefore, you'd have to increase the dial percentage on the desflurane vaporizer to deliver the same partial pressure, otherwise you would underdose the patient. So desflurane, constant deliverer of percentage, but you have to change the dial to deliver the same partial pressure that you would at sea level. Now let's look at the isoflurane variable bypass vaporizer that's been calibrated at sea level and set at 1 Mach or about 1.2%. Now the isoflurane vaporizer is open to the atmosphere around it. So when you take it up to altitude where the atmospheric pressure around it is lower, I like to think of the little liquid vapor molecules being able to jump up into the vapor phase easier because there's less atmospheric pressure pushing down on it. So even though your dial is set at 1.2%, calibrated at sea level, when you take it up to a higher altitude where the atmospheric pressure is lower, it delivers more than 1.2%. So let's use an example mathematically. 1.2% isoflurane at 1 atmosphere, 760 millimeters of mercury, times those together, that gives you 9 millimeters of mercury is 1 Mach isoflurane. And 9 millimeters of mercury would be the way to express isoflurane as a partial pressure. Now, if you set the isoflurane vaporizer at the 1.2%, but you take it from sea level now up to 7,000 feet where the atmospheric pressure is only 600 millimeters of mercury, that then becomes 1.2% times 600, which is a lower partial pressure. But fortunately, I guess, we could say fortunately, the vaporizer changes its output. And so instead of 1.2%, it ups its output and keeps the same partial pressure delivered to the patient, or about 9 millimeters of mercury. So the isoflurane and the sevoflurane vaporizer kind of auto-regulate themselves and are constant partial pressure deliverers, but not constant percentage deliverers. Next concept is uptake and distribution, and the graphic on the top right is an FA over FI versus time curve. FA is alveolar, FI is inspired, and when what you are delivering to the patient, inspired, equals what's in the alveolus, then the ratio is 1. And so this is graphically showing the uptake of volatile anesthetics. And you can see that halothane is the slowest uptake, and desflurane and nitrous oxide are very fast uptake. And these are rated basically based upon their blood gas solubility. Halothane has a very high blood gas solubility and a slow FA over FI, or slow uptake, while desflurane has a very low blood gas solubility and has a very fast uptake. So the lower the blood gas solubility, the faster the FA over FI rise towards 1. And desflurane has a lower blood gas solubility than sevoflurane, which has a lower blood gas solubility than isoflurane. So desflurane is the fastest. Now you look at the curve and say, wait a second, nitrous oxide is the fastest in this curve. And even though nitrous oxide has a blood gas solubility that is more soluble than desflurane, desflurane is about 0.42 and nitrous oxide is 0.49. Why is nitrous oxide faster? And the answer is concentration effect. If you delivered 6% des and 6% nitrous oxide, desflurane would have a faster FA over FI, but we deliver 40 to 60% nitrous oxide, and that concentration effect takes over and speeds it up a little bit faster than does desflurane. How can we increase FA over FI? Choose a low blood gas solubility agent, fast onset. We can increase the alveolar ventilation, turn up the minute ventilation, tidal volume, and respiratory rate. That affects the soluble agents like isoflurane more than it does the insoluble agents like desflurane. A low cardiac output, that trauma patient who's bleeding, the FA over FI is actually speeded up. And then second gas effect, using nitrous oxide with one of our other anesthetics. The nitrous oxide can be taken up very rapidly and concentrate the remaining anesthetic in the alveolus, speeding its FA over FI. Now this isn't a great clinical effect, but it does to some extent increase the FA over FI. What are some things that decrease the uptake? High blood gas solubility. So iso and sevo and halothane are less than des and nitrous because their blood gas solubility is higher. They're more soluble. A high cardiac output, the very anxious patient who's tachycardic, hypertensive, high cardiac output. Lots of blood going by the alveolus, and I like to think of it as the blood taking up the volatile anesthetic from the alveolus and not allowing the partial pressure to rise in the alveolus. This affects the soluble agents like isoflurane than it does the insoluble agents like desflurane. Another example that can decrease uptake is a right to left intracardiac shunt or an intrapulmonary shunt. Now, the example of an intrapulmonary shunt would be a main stem intubation. You put the tube a little bit too deep down the right side, and you're ventilating only the right lung, and the left lung is getting no ventilation, no delivery of anesthetic, but continues to receive blood. That's a large shunt. And this dilutional effect of shunted blood that bypasses the alveolus and is not picking up any anesthetic on the partial pressure of anesthetic in the blood coming from the ventilated alveoli is to reduce it. And so it decreases FA over FI. And in this case, it does it more for the insoluble agents, desflurane, than it does for the soluble agents. So these are the things that can increase or decrease uptake and distribution. Second gas versus concentration effect is the next keyword. Concentration effect basically says that the greater the inspired concentration, the greater the rise of FA over FI. And the example of this is on the far right of 70% nitrous oxide versus 10% nitrous oxide. And you can see that the higher concentration, 70%, has a faster uptake. The second gas effect is a special case of the concentration effect where combining two anesthetics like nitrous oxide and a volatile anesthetic together results in a faster uptake. And the example is on the far right in black where you have 0.5% halothane in 10% nitrous versus 0.5% halothane in 70% nitrous. Now the nitrous has an extremely high partial pressure. You're delivering 50%. 50% of 760 would be about 380. So there's a pretty high partial pressure nitrous oxide being delivered. Even though it has a low solubility, there's a lot of it taken up from the alveolus. And as it's taken up from the alveolus rapidly, it concentrates the halothane or the other volatile anesthetic that's left in the alveolus and speeds the onset. That's the second gas effect. Uptake and distribution, some special situations, infants and pregnancy. Both infants and pregnancy speed the uptake. In infants, why is the uptake more rapid? One, they have a higher alveolar ventilation if they're breathing spontaneously. They have a somewhat smaller FRC, not a lot, but a little bit per kilo less. A greater proportion of our cardiac output of the infant goes to the brain, the vessel-rich group, and the inhaled anesthetics are less soluble in infants because infants have a higher water content, let's say 80% water, while an elderly patient might be 55 or 60% water. So inhaled anesthetics decrease solubility, more blood going to the brain, lower FRC, higher alveolar ventilation, all those things combined together to have a more rapid uptake in infants. In pregnancy, volatile anesthetic uptake is also more rapid. Several things: increased minute ventilation, you're breathing more, and a lower FRC speeds the onset and rate of rise of the partial pressure in the alveolus of the lungs. Volatile anesthetic biotransformation is the next key word. Metabolism. Although halothane is not used anymore, it was the most metabolized, about 20%. While sevoflurane is about 2 to 5% metabolized, isoflurane about 0.2%, and desflurane about 0.02%, nitrous oxide very little, and xenon, if you had access to it, is not metabolized at all. So I call this the rule of twos, where sevo is about 2%, iso about 0.2%, and desflurane about 0.02%, to remember that sevoflurane of our modern volatile anesthetics is the most metabolized. Desflurane, in the presence of a dry CO2 absorber, can produce carbon monoxide, which binds to hemoglobin, forming carboxyhemoglobin. And the way to tell that this is occurring is to send a blood gas, put it through a co-oximeter, because our pulse oximeters will not pick this up, because carboxyhemoglobin absorbs similarly to oxyhemoglobin. Sevoflurane, in the presence of either a dry or a moist CO2 absorber, can produce compound A, which in the past we were worried about potential for renal injury, and now we know that that doesn't seem to be a big problem. Halothane hepatitis or immune-mediated hepatic injury. Halothane was the classic bad actor in this case. Isoflurane and desflurane, there's case reports. It doesn't seem to have occurred with sevoflurane. This does not seem to be a big problem with volatile anesthetics other than halothane. Free fluoride ion, these volatile anesthetics have carbon fluoride bonds. Sevoflurane is the most metabolized, about 2 to 5% of our volatile anesthetics, and the free fluoride ion goes up the highest with metabolism of sevo versus iso or des. But there's no evidence of that classic fluoride-induced high output renal failure that occurred, for example, with methoxyflurane, where high concentrations of fluoride, greater than 50, resulted in a ADH blocking effect at the kidney, such that you don't reabsorb water and you'd have a high output renal failure. Although fluoride ion goes up with sevoflurane, it does not seem to cause that high output renal failure. There's some recommendations by the National Institute of Occupational Safety and Health for trace gas concentrations in the operating room. And if you're using sevo or iso or des alone, you're not supposed to exceed 2 parts per million present as trace gas in the environment around us, and nitrous oxide alone at 25 parts per million. If you combine them together, halogenated agent is not supposed to exceed 0.5 parts per million, and nitrous still that 25 parts per million. But the one, since we rarely are using nitrous oxide anymore, the halogenated agent alone, like sevoflurane, des, or iso, would be 2 parts per million. Now, if you can smell the volatile anesthetic around you, such as in the case of doing an inhaled volatile anesthetic induction with sevoflurane, you're way, way, way above 2 parts per million. Here's a question. Which one of the following inhaled anesthetics is appropriately matched with an associated complication? Sevoflurane and immune-mediated hepatic injury? No, that was halothane. Isoflurane and CO2 absorber fires? Actually, sevoflurane causes the highest temperature inside the CO2 absorber and has been associated with fires in the airway in a very small number of patients. Desflurane and carbon monoxide? Yep, desflurane in a dry CO2 absorber, carbon monoxide can be formed. Sevoflurane and fluoride-induced nephropathy? Yes, sevoflurane is associated with the highest fluoride levels of our modern anesthetics, but it doesn't cause nephropathy. Let's go on to the next keyword, which is volatile anesthetics, cardiovascular effects. Our inhaled volatile anesthetics are vasodilators of the peripheral vascular system and decrease blood pressure. They result in a reflex increase in heart rate as the blood pressure decreases, and they do decrease myocardial contractility, but in general there's maintenance of cardiac output because you vasodilate, reflexively increase heart rate, and cardiac output is maintained. You cannot tell the difference between sevoflurane, desflurane, and isoflurane on mean arterial pressure at equal MAC concentrations. Therefore, 1 MAC of sevo, 1 MAC of des, 1 MAC of iso will decrease mean arterial pressure approximately the same. Our volatile anesthetics prolong the QT interval on the electrocardiogram, and there's been worries in the past that if a patient has a long QT already for some reason, could be congenital, and you expose them to a volatile anesthetic, could this result in torsades de pointes? And the answer is that patients with prolonged QT syndrome have been anesthetized safely with our modern inhaled anesthetics. Most of them are concurrently on beta-blocking drugs, which is the treatment for long QT syndrome. But in most cases, I think many people would use a TIVA-based anesthetic in a patient with congenital long QT syndrome. Desflurane and the sympathetic nervous system, if you rapidly change the concentration of desflurane, for example, 0% up to 10%, there is sympathetic nervous system activation with increase in circulating norepinephrine. Now, this can occur in the middle of an operation. Let's say you're on 5% des, the patient moves, and you crank the desflurane up to 12%. You could get this sympathetic nervous system stimulation and the increase in norepinephrine. It's transient, occurs over minutes, and it fatigues with time, meaning that if you took a patient and went from 0 to 10%, 0 to 10% multiple times, eventually the patient says, aha, I know what you're going to do next, and it fatigues and you don't get nearly as much of the sympathetic nervous system activation. It probably is related to irritation of receptors in the airway by the desflurane, which then results in stimulation of brainstem and the sympathetic nervous system activation. Desflurane, even though it can activate the sympathetic nervous system, is not contraindicated in patients with coronary artery disease. Next keyword topic is volatile anesthetics and central nervous system effects. When we talked about the intravenous agents, we said that they put the brain to sleep, and when the brain goes to sleep, it doesn't need as much oxygen, doesn't use as much oxygen, and there was a decrease in cerebral metabolic rate for oxygen. The volatile anesthetics also decrease the cerebral metabolic rate for oxygen, but unlike the intravenous agents like etomidate and propofol, they actually increase cerebral blood flow. So we have cerebral metabolism going down at the same time that cerebral blood flow is going up. The volatile anesthetics are vasodilators of not only the systemic vasculature, but the cerebral vasculature. And if blood flow goes up to the head and there's more blood in the head with the volatile anesthetic, there's a possibility that you can increase intracranial pressure, but this effect is blunted by hypocapnia, such that if you hyperventilate the patient as you're introducing the volatile anesthetic, there's not a rise in intracranial pressure. What is the effect of the volatile anesthetics on the electroencephalogram? And the graphic on the far right is meant to demonstrate that. In the awake state, you can see that the EEG is a very high frequency, low amplitude pattern, and the BIS is reading close to 100. As you get higher levels of concentration of the volatile anesthetic, patients sedated more, the amplitude of the EEG goes up, and the frequency decreases. It spreads out between each of those peaks. And the BIS is dropping now towards 80. And then during surgical anesthesia, we classically think of a BIS being somewhere between 40 to 60. And you can see the high amplitude and very low frequency. You're heading down towards the delta and theta waves. And as you increase the volatile anesthetic up to, let's say, approximately 2 MAC, you can start to get burst suppression and even suppression, or isoelectricity. And at total suppression, the BIS reads 0. Sevoflurane is somewhat unique, and it's associated with emergence delirium in kids. And this emergence delirium doesn't seem to be decreased with midazolam co-administration. And pain may be a confounding factor, but when you have kids who are administered sevoflurane, some of them wake up very squirrely, emergence delirium, and occasionally we'll use drugs like low-dose dexmedetomidine intravenously before the end of an operation in an attempt to reduce this emergence delirium. What do volatile anesthetics do to SSEPs and MEPs? Well, the somatosensory evoked potentials that are often used to monitor the neural pathways during surgery, such as back surgery, the volatile anesthetics make the amplitude of them go down and the time for them to go through the neural pathways longer, the latency longer. So it makes it more difficult to monitor SSEPs if you're using very high concentrations of volatile anesthetics. Now, if you were just doing SSEPs without MEPs, you can use less than 1 MAC of a volatile anesthetic. We paralyze the patient with a neuromuscular blocking agent to reduce the background muscle noise, and we can monitor SSEPs quite effectively. However, if MEPs, motor evoked potentials, are co-monitored with SSEPs, then you have to be very careful, because the volatile anesthetics greatly decrease motor evoked potential signals, and usually we will use a TIVA-based anesthetic, for example, propofol and remifentanil, without neuromuscular blockade, so that we can see those motor contractions and also monitor SSEPs at the same time. What are the respiratory effects of the volatile anesthetics? The next key word. Under sevoflurane, for example, without neuromuscular blockade or co-administration of opioids, patients alveolarly hypoventilate, and what happens is there's a panting like that is seen. The respiratory rate goes up, not infrequently. If you have an LMA down, breathing sevoflurane, the respiratory rate might be 25. The tidal volume, instead of a normal 450, drops often to 200, for example. And these volatile anesthetics are causing alveolar hypoventilation and a rise in arterial CO2 and end-tidal CO2. So that panting is that increased respiratory rate and decreased tidal volume. And the normal ratio of dead space to tidal volume is about 0.3. That is, dead space is about 150 mils just to get air down your trachea to the gas exchanging alveoli. And normal tidal volume about 450, so the ratio of 150 over 450 is about 0.3. But if you're breathing a volatile anesthetic and your tidal volume goes down, let's say to 300, now the ratio is 150 over 300, or a dead space to tidal volume ratio of a 0.5. So you can see why there's an increase in end-tidal CO2, and it's not uncommon to see your end-tidal CO2 rise up into the 50s when someone's breathing spontaneously through an LMA with sevoflurane. And not only does the end-tidal CO2 to go up, but if you try to drive it down lower by taking over ventilation, you grab the bag and ventilate them down to an end-tidal CO2 of 40, they often will not breathe on their own because the apneic threshold is increased with the volatile anesthetic. Volatile anesthetics profoundly decrease the ventilatory response to hypoxia, such that if even 0.1 MAC concentration of the volatile anesthetic is present and you became hypoxic, normally you would hyperventilate. But with the presence of the volatile anesthetic around at the same time that hypoxia is present, patients don't hypoventilate, that is, hyperventilate, like they should. Also, the ventilatory response to carbon dioxide is affected by volatile anesthetics, but it takes more of the volatile anesthetic to block that CO2 response. So it's the hypoxic response that takes very little to profoundly affect. More of the volatile anesthetic to affect the CO2 response, which is if the CO2 goes up, we should hyperventilate, and under volatile anesthesia, we do not hyperventilate as much. The volatile anesthetics are bronchodilators, iso, and des of the lower airways, and we know that desflurane is the classic one for irritating the upper airways. The volatile anesthetics also are vasodilators and can attenuate hypoxic pulmonary vasoconstriction. Here's a question for you. Which one of the following inhaled anesthetics is appropriately matched with an associated physiologic effect? Does desflurane increase CMRO2? No. It increases the cerebral blood flow, but cerebral metabolic rate for oxygen goes down. Does isoflurane decrease cardiac output? No, it's maintained. Does sevoflurane increase SSEP amplitude? No, it decreases amplitude and increases the latency, the time for the signal to get through. Does desflurane decrease hypoxic pulmonary vasoconstriction? The answer is yes, D. Which one of the following will occur in a patient spontaneously breathing 2 MAC inhaled isoflurane? Decreased apneic threshold? No, the apneic threshold is higher. Takes more CO2 to drive our breathing. Increased minute ventilation in response to hypoxia? No, that's blunted or totally blocked, as the 2 MAC of inhaled isoflurane blocks the hypoxic response. Increased minute ventilation in response to hypercarbia? Nope, 2 MAC blocks that. Increased dead space ventilation? Yep, because the tidal volume is lower and the dead space stays the same at 150, and more VD over VT, the ratio goes above the 0.3, higher and more goes to dead space, and there's less alveolar ventilation. Let's move on to pharmacokinetic, a keyword review. The first thing I'd like to talk about is volume of distribution, which is a mathematical term expressed in liters. If you gave a known amount of drug and then measured the plasma concentration at equilibrium that occurs after that drug is given. We know that lipid-soluble drugs go all over in the body and have a very high volume of distribution in the hundreds of liters. Well, obviously we're not hundreds of liters, again emphasizing the fact that this is a mathematical term. Water-soluble drugs go to the water space of the body, and there's a low volume of distribution in general, and these are, as example, the neuromuscular blocking agents, large, polar, ionized molecules that go to the water space of the body. Potency refers to the relative dose of two drugs to have a similar effect. Fentanyl obviously is more potent than morphine, about 100 times is more potent than morphine, and efficacy refers to the ability of a drug to produce a physiologic or clinical effect. And the graphic at the top right is meant to demonstrate the difference between potency or affinity and efficacy or activity. Potency, if something's less potent, it takes more of the drug to have an effect, and we want to know whether that drug is actually going to be able to have an efficacious effect. It's going to drop the blood pressure a certain amount, or increase the blood pressure a certain amount, or increase the heart rate a certain amount, etc. Kinetics. First order kinetics versus zero order kinetics. And in the bottom right is a graphic demonstrating this. Zero order elimination, we think of alcohol being an example. First order elimination is most of our drugs. And in the first half-life, you get rid of half of the drug. So if you had 100%, you decrease to 50% left. You've gotten rid of 50%, you have 50% left after one half-life. After two half-lives, you get rid of what is left of the 50%. Half of that's 25. So now you've gotten rid of 75% of the drug and have 25% of it left at two half-lives. Half of 25 is 12.5. So at three half-lives, you've gotten rid of 87.5% of a drug and only about 12.5% left. Therefore, the concept that it takes about three half-lives to get rid of the drug from a body. Pharmacogenetics, continuation of how drugs are eliminated from the body, metabolized. Phase 1 versus phase 2 reactions. Phase 1 reactions we think of as the oxidation, reduction, and hydrolysis of drugs, usually involving the cytochrome P450 system, an example being the CYP2D6 enzyme that is so important for many of our drugs' elimination. In fact, about 25% of our drugs. Anticonvulsant drugs like Dilantin and Tegretol can induce this enzyme, ramp it up, and make it work even faster, while some of our psych drugs and our SSRIs and our HIV treatment drugs can actually inhibit the enzyme. And therefore, for example, if you had a patient on an HIV drug, SSRIs, some of them, or some of our psych drugs, who then you gave a drug like midazolam that requires the enzyme to chew it up, midazolam would have a greater effect because the enzymes are inhibited that should be breaking it down. Poor metabolizers, about 7 to 10% of Caucasians are these poor metabolizers that have an abnormal CYP2D6, and if you give them codeine, for example, it's a prodrug. Codeine has to be converted to morphine. They're not going to do it very well because they don't have a normal enzyme. And there are others that are ultra-lipid metabolizers, so there's wide variations in this CYP system. Weaker opioids, as we mentioned, are metabolized to more potent opioids: codeine, dihydrocodone, tramadol, hydrocodone, oxycodone to morphine, hydromorphone, and oxymorphone. So a lot of our opioids depend upon the CYP system to be metabolized to more potent forms. No significant effect on fentanyl, remifentanil, and sufentanil. So in the example on the right, you can see a drug going to its metabolite via oxidation by the cytochrome P450 system. When it's oxidized, it's converted to a more polar species that then can be renally eliminated. Now, another form of metabolism is phase 2, and conjugation is an example of that, where you add a molecule to the drug to make it usually more water soluble, so that it can be excreted in the kidneys or possibly biliary excreted into the stool. Conjugation with a drug like a sugar, glucuronate. So morphine 6 glucuronate would be an example where morphine has a sugar put on it in the 6th position, creating a metabolite which is still active. Morphine 3 glucuronate is a glucuronate molecule in the 3 position on morphine, and that is not active, but is a metabolite that can then be excreted. Now, an example I'm providing here is lorazepam as opposed to midazolam. Lorazepam undergoes a conjugation metabolism, as opposed to midazolam, which undergoes a phase 1 or oxidation type metabolism. So drugs that inhibit the CYP system, as mentioned before, like the HIV drugs, would inhibit the metabolism of midazolam, but not lorazepam. Pharmacogenetics is the next key word. The CYPD system we've talked about. Codeine must be metabolized by that system to morphine, and if there's a genetic abnormality of that enzyme, codeine is not going to work as an opioid pain reliever. It's not very effective anyway, but especially not effective if it's not metabolized to morphine. Atypical cholinesterases, pseudocholinesterase deficiency or genetic abnormality. If you have a problem with that enzyme, succinylcholine is not going to be metabolized normally, and ester local anesthetics. But remember, remifentanil is broken down by nonspecific esterases and esmolol by RBC esterases. So an atypical cholinesterase, atypical pseudocholinesterase, would not cause a metabolic difference breakdown in remifentanil or esmolol. Malignant hyperthermia, we know that succinylcholine and or volatile anesthetics can trigger malignant hyperthermia in genetically susceptible individuals. G6PD, glucose 6-phosphate dehydrogenase. Apparently this is the most common human enzyme defect, and when a patient with G6PD deficiency is exposed to certain drugs like ones that we might administer, methylene blue as a treatment for methemoglobinemia, or nitrates for the treatment of myocardial ischemia, can result in hemolysis of red blood cells when these triggers are administered to patients with G6PD deficiency. AIP, or acute intermittent porphyria, we mentioned that barbiturates are contraindicated in patients with AIP, and there's some other drugs listed here that would not be wise to administer to someone with AIP, but barbiturates are the classic one to avoid. The next key word is context-sensitive half-time, which is a mathematical model describing the time required for the central compartment drug concentration to fall by 50% or in half as a function of the duration of an infusion. So basically what this is saying is what happens to drugs as we infuse them over time, hours, when we turn them off. Which ones are good to infuse for long periods of time, knowing that you'll have a predictable offset. And you can see on the left at the bottom that etomidate and propofol and ketamine have a pretty favorable context-sensitive half-time for infusing for extended periods of time, because they're not building up the time that it takes with the duration of the infusion that it would take for the concentration to fall by 50% when you turn it off at the end of an infusion, as opposed to Valium and thiopental, not good drugs for long-term infusions. But opioids are the classic example on the bottom right, where you can see remifentanil have a very flat context-sensitive half-time at an hour versus 10 hours. Remifentanil, when you turn it off, there's pretty much the same amount of time for it to drop, the drug concentration to fall by 50%. Sufentanil, pretty favorable context-sensitive half-time for infusions, but you can see that fentanyl has a very unfavorable context-sensitive half-time, and therefore if you're using high concentrations of fentanyl, high doses that is, and are infusing for long periods of time, it's going to take a long time when you shut it off to drop by 50%. Why can we get away with fentanyl infusions and still wake up a patient? Because we're not using high doses. Some miscellaneous pharmacology topics now. First one is anticholinergic side effects. Anticholinergics are drugs like atropine, scopolamine, and glycopyrrolate. Atropine and scopolamine are tertiary amines. NH3, they're uncharged. Uncharged molecules can cross the blood-brain barrier and have an effect in the brain. Glycopyrrolate is quaternary amine. NH4+, charged, does not cross the blood-brain barrier. So it's the tertiary amines, atropine and scopolamine, that can cross the blood-brain barrier and cause things like CNS effects of dilated pupils and the classic central anticholinergic syndrome, where a patient can be very confused and sedated and somnolent, and if you believe that that's the cause, the scopolamine or atropine causing the central anticholinergic syndrome, physostigmine, which crosses the blood-brain barrier and inhibits acetylcholinesterase in the central nervous system, raising acetylcholine levels back towards normal and hopefully reversing the central anticholinergic syndrome. Physostigmine, antilirium is the antidote. Tachycardia can occur with anticholinergics. Suppression of sweating. And in kids, if you suppress sweating and you're in a hot environment, you can see how an anticholinergic drug could result in an increase in body temperature. They relax the lower esophageal sphincter. and they also are bronchodilators and can increase the physiologic dead space. Antiemetics now, next key word. And let's look at the site of action of these first. There are some prokinetic drugs like Reglan that help move fluid and food through our GI system. They work at the dopamine receptor. Serotonin agonist, the classic being ondansetron, is a serotonin receptor, is where it has its effect. Antimuscarinics, drugs like atropine and scopolamine, act at muscarinic receptors. We put scopolamine patches on patients for its antiemetic effects. We occasionally use drugs like Vistaril, antihistamines, because of their histamine receptor effects. There's some newer ones like aprepitant that is a neurokinin antagonist. Slower onset, potent antiemetic effect, and quite expensive, aprepitant that is. And then there's other ones like dexamethasone and propofol, midazolam, and even cannabinoids that have antiemetic effects. Let's look at risk factors for postoperative nausea, vomiting in adults versus children next. Adults, if you have a female who doesn't smoke, who says every time I get in a car and drive up a curvy road I throw up, who you're going to give lots of opioids in the postoperative period and is undergoing laparoscopic procedure, that would be the ultimate high chance of having postoperative nausea and vomiting. Kids a little bit different. So the risk factors that are known are longer duration of surgery. The really young, not as high a risk. The greater than 3 years, the higher risk. If you're having eye surgery and a history of postoperative vomiting or a relative with PONV, puts that child at risk. And when you have multiple risks combined together, we think, I better use some type of intervention. If they're at medium risk, we use one or two of these pharmacologic interventions. And if there's very high risk, we'll use multiple interventions and multimodal approach, often combining dexamethasone with ondansetron and possibly a scopolamine patch, unless the patient is very old. Elderly patients putting a scopolamine patch on, that patient may end up with central anticholinergic syndrome. Now, what if treatment options fail? At the bottom, if prophylaxis fails or was not received, use an antiemetic from a different class. So don't just redose the same antiemetic that you used before. And re-administer only if greater than 6 hours after PACU. For example, ondansetron redosing. And do not re-administer the steroid or the scopolamine if you were using them. So if someone had gotten dexamethasone and gotten ondansetron and was throwing up in the recovery room, something like a dopamine blocker like prochlorperazine or something like that might be utilized. It's a different class of drug. Antiemetics and some problems with them. QT prolongation, classically with droperidol, but also can occur with 5-HT3 antagonists like ondansetron or dilasetron. If you prolong the QT interval, as shown in the graphic on the far right, from a normal on the left to a prolonged QT interval on the right, if the QT corrected is greater than 440 milliseconds, we say that's a prolonged QT interval, and there's a risk of torsades de pointes. So if someone already has a prolonged QT interval, we think twice about using drugs like droperidol and ondansetron. Our steroids can raise blood sugar, especially in diabetics. Dexamethasone, which is a glucocorticoid with lacking mineralocorticoid activity, dexamethasone administration can raise the blood sugar. Parkinson's disease, those patients are sometimes living on their last dopamine receptor, and if you block it with a drug like droperidol, prochlorperazine, Reglan, or Metoclopramide, that patient can become basically akinetic and not be able to move. So avoid dopamine blocking drugs in Parkinson's patients. The next key word is Metoclopramide or Reglan and its gastric effects. We usually use Reglan to help stimulate gastric motility, and we say we probably shouldn't use that drug because of its dopamine blocking effects in Parkinson's patients, because Parkinson's patients already don't have many dopamine receptors, and if we block them, they may not be able to move. So that would be a contraindication, Parkinson's disease. Also, you probably would not use Reglan in someone who's had a pyloroplasty or has an intestinal anastomosis or a obstruction of their gut. Because metoclopramide increases the resting tone of the lower esophageal sphincter, relaxes the pyloric sphincter, and the stomach empties. And if you had an obstruction or pyloroplasty, you would not want to use Reglan. It doesn't really have a very good antiemetic effect per se, and has some bad side effects like potential for extrapyramidal reactions, which could be treated with Benadryl, sedation, and occasionally hypotension and bradycardia or tachycardia can occur with Reglan. But the extrapyramidal reactions are the classic ones. H2 receptor blockers and the effect on gastric pH. It's not recommended that we routinely give H2 blockers or PPIs for that matter to patients, but we consider them in parturients, morbidly obese patients with GE reflux, and when we anticipate a difficult airway, because those are the patients that are at risk for regurgitation and aspiration. H2 blockers don't alter the pH of the gastric fluid that is already present in the stomach, but does alter the fluid that's made by the stomach, and it is a higher pH, the fluid coming out after that. So if you already had 100 cc's of acidic fluid in your stomach, it's not changing the pH of that. And it doesn't facilitate gastric emptying like Reglan did. The onset intravenously of H2 blockers is approximately an hour or so and lasts about 12 hours. Orally, approximately 1 hour or more onset. Remember that the PPIs have a longer onset, takes longer for their effect to start, but a longer duration of action. Benzodiazepines and respiratory effects, next key word. Benzodiazepines activate the GABA receptor, they depress ventilatory response to carbon dioxide, and they occasionally can cause transient apnea if you bolus, for example, midazolam. Elderly patient, big dose of midazolam could go apneic, but there's usually, when they're administered alone, minimal respiratory depression. If you give them in low doses, the patient doesn't have hepatic or renal disease, minimal respiratory depression with benzodiazepines. Remember, the metabolism of midazolam and diazepam differs from lorazepam. Midazolam and diazepam are phase 1 reaction, CYP system dependent, drug-inducible oxidases, and if a patient was given a drug like an HIV drug that inhibited, or an SSRI that inhibited these oxidases, they, if administered midazolam, would have a greater effect from the midazolam. Lorazepam undergoes phase 2 reaction, glucuronidation. It is adding a sugar molecule to the lorazepam, and it is renally excreted. There's more respiratory depression associated with benzodiazepines when you combine them with opioids. So fentanyl plus midazolam, of course, is more of a respiratory depressant than just midazolam alone. Now, if you give too much of a benzodiazepine or someone comes in with a benzodiazepine overdose, Flumazenil is a competitive antagonist at the benzodiazepine receptor, the GABA. And you can see on the far right where Flumazenil and benzodiazepines act in relationship to the GABA. And you can see that that GABA receptor is a chloride conductance channel. The Flumazenil, if it acts as a competitive antagonist at the benzodiazepine receptor, it's going to reverse benzodiazepine's effect. It is eliminated in about 60 minutes, and so if you had given a benzodiazepine in high doses like lorazepam that lasts a long time, and then you reversed it with Flumazenil, the Flumazenil has a shorter half-life than does the lorazepam, and the patient can have resedation, and you may have to repeat the doses of Flumazenil. Flumazenil lacks intrinsic agonist effects such that if I gave it to you, you would not know that you received it. You wouldn't get a change in heart rate or blood pressure or respirations or have sedation, for example, and it doesn't alter MAC. Flumazenil reverses all the effects of benzodiazepines, including sleep or hypnosis, the muscle relaxation effects, amnesia, sedation, and anxiolysis. And if someone is benzodiazepine dependent and you reverse them rapidly, you can precipitate a withdrawal and possibly even seizures. Dexmedetomidine or Precedex and its cardiovascular effects is the next key word. Both clonidine and dexmedetomidine are alpha-2 agonists, not antagonists, but agonists, and dexmedetomidine is very selective at that alpha-2 receptor. Alpha-2 receptors presynaptically, when agonism occurs at them, norepinephrine release is inhibited. So less norepinephrine release centrally and peripherally. So centrally, you're going to get sedation, a decrease in MAC, and analgesia-sparing effect, has little respiratory depression, but it does decrease sympathetic activity and can cause bradycardia and hypotension. Decreasing SVR and heart rate, so you need to be careful in patients who already have heart block or severe LV dysfunction. It indirectly decreases myocardial contractility, cardiac output, and blood pressure. And if you bolus dexmedetomidine rapidly, you can see this transient and paradoxical hypertension that occasionally occurs. And that is probably due to stimulation of alpha-2 receptors in vascular smooth muscle, resulting in vasoconstriction. So we say give the dex over about 10 minutes to avoid this transient paradoxical hypertension. If you stop dexmedetomidine infusions, you don't seem to get rebound effects, which have been associated with clonidine in the past. And we have recommendations for clonidine that we don't suddenly stop that just before an operation or take off a transdermal clonidine because you can get rebound hypertension. The physiologic effects of alpha-2 adrenoreceptors is shown graphically on the right. There's sedation, there's slowing of the heart rate, it can have an anti-shivering effect. And if you decrease sympathetic output, you can get vasodilation, and it has a morphine-sparing or analgesic-like effect, acting centrally and peripherally. Phenoldiprem is the next keyword, not used very much anymore. In the past was used as an IV antihypertensive drug because of its dopamine agonist effect, resulting in dilation of renal and mesenteric vessels. So if you wanted to drop someone's blood pressure but maintain blood flow to the kidneys, phenoldiprem was a pretty good choice. It had diuretic and natriuretic properties, and the studies have not borne out a protective kidney effect of phenoldiprem, and therefore its use is not very often in clinical practice today. Dantrolene Pharmacology, dantrolene being the specific drug treatment for MH. It blocks calcium release from the sarcoplasmic reticulum. And the graphic on the far right, the yellow where it says SR and the RY, which stands for the ryanodine receptor, if you give dantrolene, that sarcoplasmic reticulum stops spewing out calcium, but you don't block the reuptake of calcium. So the release of calcium blocked, but the reuptake is not blocked. So all that calcium that's occurring in the muscle itself during an MH episode now can be taken up by the sarcoplasmic reticulum, and the troponin tropomyosin cross-linking with the rigor of the muscles, the heat production, the carbon dioxide production, the acid production, the lactate production goes down, and the MH hopefully resolves. Prophylaxis with dantrolene in someone who's, quote, MH susceptible is not recommended. We don't do that. And one of the unique complications of dantrolene is if you combine it with a calcium channel blocker, for some reason you can get hyperkalemia and severe myocardial depression. And so the recommendation is if you're treating someone with an MH episode with dantrolene, and let's say they get a run of SVT, AFib with SVT, where you might use diltiazem or another calcium channel blocker, but usually diltiazem, you should not combine a calcium channel blocker with dantrolene. Side effects of dantrolene include muscle weakness, GI upset, sedation, and if given for a period of time, abnormal liver function tests. Dantrolene can also decrease the temperature and be used to treat neuroleptic malignant syndrome, which is neuroleptic malignant syndrome that is caused by antipsychotic medications, dopamine blocking drugs, that you can have a slow onset of MH, usually occurring over days in someone taking antipsychotic medications, but it looks very much like MH and can have rigor, elevations in temperature, and dantrolene can also be used to treat neuroleptic malignant syndrome. So here's a question for you. Common pharmacology between naloxone, which reverses opioids, and Flumazenil, which reverses benzodiazepines, include which of the following? Competitive antagonism at receptors. They do have competitive antagonism at receptors. They have a short half-life. Cardiac dysrhythmias and pulmonary hypertension after a single bolus, that occurs after naloxone. Seizures, a complication of bolus administration, that can occur after Flumazenil reversal and benzodiazepine-dependent patients. Next keyword is anaphylaxis. Type 1 anaphylactic reaction, IgE mediated. If you have lots of IgE that attaches to mast cells and basophils, they release the stuff that's inside and cause all the things that we think of associated with anaphylaxis, like bronchoconstriction and wheezing, hypotension from vasodilation, and increased capillary permeability and tissue edema. Mediated release anaphylaxis can be an antigen-antibody interaction. We say it's anaphylactoid when you have a reaction similar to anaphylaxis with the bronchoconstriction and hypotension and vasodilation, but it's not immune-mediated release, so not IgE-mediated. The mediators that are released during anaphylaxis and anaphylactoid reactions include histamine, which increases capillary permeability, causes vasodilation and bronchoconstriction, leukotrienes, which also increase capillary permeability and can cause bronchoconstriction, prostaglandins, which can cause bronchoconstriction. So we diagnose anaphylaxis in a patient who has urticaria, pruritus, hypotension, hypovolemia, even can get laryngeal edema, starts to wheeze with bronchospasm, and can also have arterial hypoxemia. Plasma histamine goes up, but it returns to baseline in about 30 to 60 minutes. So if someone has an anaphylactic episode and you measure histamine levels, they'll be up very early, but then after 60 minutes or so, they will go back to baseline. Tryptase, however, comes from mast cells, and it increases within 1 to 2 hours and remains increased for a longer period of time than does histamine. So if you think you had an anaphylactic reaction, you can send off a tryptase level, and if it is massively elevated, you can say, aha, that's confirmation from this plasma tryptase that it was anaphylaxis. We treat anaphylaxis with low doses of epinephrine, approximately 10 mics IV initially as a bolus. What causes anaphylaxis in the perioperative period? Classically, it's antibiotics and neuromuscular blocking agents, rocuronium and succinylcholine. If someone has a history of penicillin allergy in the perioperative period without anaphylaxis, can you use the classic prophylactic antibiotic cephalosporins? And the answer is yes. But if someone has penicillin allergy with anaphylaxis, we would avoid cephalosporins. Treatment of anaphylaxis, as we mentioned, was epinephrine. Why? Give it early, number one, and the why is because it does two major things. One, its beta agonist effect relaxes bronchial smooth muscle, causing bronchodilation, beta 2 effect, and it increases intracellular cyclic AMP, stopping those mast cells and basophils, that is, from secreting the stuff that's in them. So it restores membrane permeability and decreases the release of those vasoactive mediators. So it not only is treating the problems of anaphylaxis, but is stopping the release of the mediators that are causing anaphylaxis. So give epinephrine early is the take-home message. Ketoralac or Toradol in renal function. Non-steroidal anti-inflammatories block prostaglandins, and prostaglandins are mediators of renal blood flow. So if you decrease prostaglandins, you can reduce renal blood flow, and you can cause acute renal insufficiency in some patients. There's a predisposition in the elderly, the critically ill, those with congenital heart failure, renal or hepatic dysfunction, and production of renal dysfunction is more likely in patients with advanced age and coexisting renal hypoperfusion, as well as hypovolemia, sepsis, major surgery, etc. There's some other renal effects of Ketoralac like proteinuria, interstitial nephritis, papillary necrosis, and we're told to not exceed at least a couple days or so of IV or IM dosing in the perioperative period. But NSAIDs appropriately administered can be part of our pain control, multimodal pain control therapy. Herbals and supplements, what do we do with them in the perioperative period? Our next keyword. If possible, discontinue them 7 to 14 days before surgery, one exception being valerian, a CNS depressant, where you don't want to just rapidly stop that CNS depressant that someone's gotten used to. Mandatory discontinuation of herbals or cancellation of anesthesia when someone continues to take their herbals up to the time of surgery is not supported by evidence. So if someone came in and had taken their herbal, most people would not cancel the surgery. It's also not a contraindication to doing neuraxial anesthesia according to ASRA guidelines, someone who's taken herbals. But remember that the G herbals can interfere with anticoagulants or antiplatelet drugs and can impair platelet function. The G herbals being garlic, ginseng, ginkgo, and ginger. One of the commonly missed questions from the basic exam as published by the American Board of Anesthesia this last year was that ginseng can actually lower blood sugar levels, and if someone takes ginseng in the perioperative period, their blood sugar can drop, and there's a risk of hypoglycemia, especially in fasted patients. Diuretics, next keywords, furosemide versus mannitol. Furosemide, a loop diuretic that has an onset quite rapidly, about 5 minutes, peaks in about 20 to 60 minutes, and persists for several hours. It's inhibiting sodium and chloride reabsorption in the loop, and also not only does sodium and chloride reabsorption be decreased and be peed out, but also calcium and magnesium and water. So you're diuresing water, and not only do you lose electrolytes and water, but when you give Lasix, you venodilate. Even that occurs before the diuresis starts. So someone with congestive heart failure who you bolus with Lasix in hopes to get rid of some of the fluid in them, one of the first beneficial effects of Lasix is the venodilation, decreasing preload, decreasing the LVEDP in a patient with heart failure, and then the diuresis. If you give Lasix multiple doses over time, that contraction, metabolic alkalosis can occur, and hearing loss and hyperuricemia are other things that are associated with furosemide. Mannitol is an osmotic diuretic that can lead to volume depletion and also the loss of electrolytes like sodium, potassium, and magnesium. We've given it in the past to try to prevent acute renal failure, where it's not effective when used in that manner, but we do use it in renal transplantation at the time of reperfusion. Mannitol can be used to decrease intracranial pressure. It acts in about 30 minutes or so with its maximal effect in 1 to 2 hours, but remember that as mannitol is given, it being an osmotic diuretic, it draws fluid initially into the intravascular space and can initially raise intravascular volume. And in someone with an EF, let's say of 15%, that you gave them a big dose of mannitol, you could precipitate congestive heart failure. And Lasix might be a better choice in that situation than mannitol. Diuretics, and where do they work? The thiazide diuretics versus acetazolamide or Diamox, which is a carbonic anhydrase inhibitor, versus spironolactone, the aldosterone antagonist. They're color-coded here that thiazides, green, act at the distal convoluted tubule, and they're not very effective when someone has a really bad kidney. And you know that if someone has a really bad kidney, we crank it up and give Lasix or Bumex to them instead of thiazide diuretics. But thiazide diuretics are still used as part of antihypertensive therapy, and patients who are taken hydrochlorothiazide, for example, can come in hypokalemic with a metabolic alkalosis like Lasix caused. But something unique to the thiazides is this hypercalcemia, and like Lasix also can cause hyperuricemia. Acetazolamide or Diamox works in the proximal renal tubule, represented by the light blue in the figure at the far right, and it inhibits carbonic anhydrase such that you don't absorb bicarbonate. You pee bicarbonate, and so you alkalinize the urine, and if you're losing bicarbonate in the urine, then you become metabolically acidotic. And the classic case would be someone like who has glaucoma and has taken Diamox eye drops in their eye, and that is used to reduce aqueous fluid production in that glaucoma patient. But if you drew a blood gas from them, you might see a metabolic acidosis. Someone who's going up to high altitude and takes Diamox prophylactically It will cause a bicarbonaturemia, peeing bicarbonate, a metabolic acidosis, so that they will continue to hyperventilate in response to the low atmospheric pressure at high altitude. It also shifts the oxyhemoglobin dissociation curve in a favorable direction and is used when you're ascending to high altitudes prophylactically to help you acclimate. Spironolactone is an aldosterone antagonist. It's purple color here, and you can see at the far right where it's acting in that distal nephron. And being an aldosterone antagonist, it is inhibiting sodium and potassium excretion. So basically, here's what happens. Normally, aldosterone causes you to pick up sodium and excrete potassium. So if you're blocking aldosterone's effect, you're not going to excrete the potassium as much, and you can actually cause hyperkalemia. So it is a weak diuretic used sometimes in patients who have congestive heart failure. More commonly, it seems, in patients with a liver failure who have high aldosterone levels, and you can block the aldosterone effects of reuptake of sodium and excretion of potassium. But remember that if you're blocking aldosterone effects of excretion of potassium, the secondary effect could be hyperkalemia. Anticoagulant action, next key word, warfarin. What does warfarin do, or Coumadin? It inhibits the synthesis of vitamin K-dependent clotting factors. Those vitamin K-dependent clotting factors are 2, 7, 9, and 10. And don't forget that it also has an effect on protein C and S. We monitor the prothrombin time in INR in patients on warfarin. Low molecular weight heparin. Heparins bind to antithrombin 3, which then accelerates antithrombin's inhibition of clotting factor 10A. Now, plain heparin, unfractionated heparin, also acts on antithrombin 3, but then it acts on multiple places in the clotting factor cascade. So low molecular weight heparin, inhibition of factor 10A via antithrombin 3's effect, not having its effect on thrombin itself. We monitor low molecular weight heparin, its effects almost never, but if you needed to, you would monitor anti-factor A activity. We would not draw a PT-INR or a PTT. Fondaparinux is a drug that inhibits 10A via antithrombin. It's not a direct thrombin inhibitor. It tends to have less chance of HIT or heparin-induced thrombocytopenia than does heparin, and doesn't increase the PT and PTT. So drugs that we use to prophylax against patients developing DVT, for example, low molecular weight heparins, think of it acting via antithrombin 3 and then factor 10A. Heparins themselves, unfractionated forms, as opposed to the low molecular weight heparin fractionated form, they bind to antithrombin 3 also, but antithrombin 3 inactivates thrombin, 10A, and other proteases, and we monitor PTT for its action. So the graphic at the far right shows warfarin acting at 2, 7, 9, and 10. Factor 10A inhibitors, several listed there, and direct thrombin inhibitors, which we're going to talk about next, one example being dabigatran. Anticoagulant action, keyword, this is part 2 of that. Clopidogrel or Plavix, where does it work? Plavix is a prodrug that requires activation by a CYP system, so you can see why Plavix may not work in some patients if they don't have that normal enzyme to convert the prodrug to its active form. In its active form, it acts on the ADP receptor on platelet membranes, irreversibly inhibiting them, and platelets don't work as well. Many patients are on Plavix. In the perioperative period, this can be a major problem. Bivalirudin, Angiomax, is a DTI or direct thrombin inhibitor. It's cleared by the kidney, and so someone with kidney problems, you would likely avoid bivalirudin, that DTI. There's other choices of DTIs if you needed them. Dabigatran or Pradaxa is an oral direct thrombin inhibitor, which has a pretty long half-life and does prolong the PT, PTT, and INR, but not linearly, and we tend not to monitor its effects. So drugs used to treat clotting disorders are summarized on the far right. You can see the DTIs, drugs like dabigatran, argatroban, the indirect thrombin inhibitors that work via antithrombin 3, one being heparin that works via antithrombin 3. There are the vitamin K dependent drug warfarin, affects 2, 7, 9, and 10. The direct 10A inhibitors, rivaroxaban, apixaban. The COX inhibitors that affect platelets like aspirin. The glycoprotein 2B, 3A inhibitors like abciximab. And then the ADP inhibitors like clopidogrel. So aspirin and Plavix affect our platelets. And then there's thrombolytics that are used for arterial and venous thrombosis, things like streptokinase. This ends our 3-part series pharmacology review, and I hope that you learned something from this review, and hope you have a wonderful day. This is the Dolomites in Italy, a great place to bike if you ever have a chance. Have a good day.